So today we're hosting an informational webinar called Implementing Diagnostic Excellence Across Systems, otherwise known as the IDEAS Project. At the end of the webinar, we'll leave ample time for questions, but if you have any questions, you know us. Please go ahead and put that question into the chat box, and we'll be sure to answer your question in real time if we can, and if not, we will do so at the end of the webinar. If you have not used Zoom before, go ahead and find your toolbar and you'll be able to pop up that chat box using that chat box button. And then there you'll be able to write any questions you may have. Another housekeeping item is closed captioning. If you would like to enable closed captioning, again, go to that toolbar at the bottom or top of your screen and click that CC button, and that will help you to enable closed captioning should you need it. So my name is Alex Stack. I'm a senior advisor with Convergence Health, and I'm joined by several of my colleagues today. One is Kim Workmeister. She is the Senior Vice President of Improvement and Implementation. And I'm also joined by Jen Wagner, who is the Director of Rural Health Initiatives. On the other end, we also have some of our RAN friends who are critical to this project. Dr. Courtney Gedengel. She is a Senior Physician Researcher at RAN, and she also works part-time doing infectious disease at Boston Children's Hospital. Dr. Sanjita Alawalia is a Senior Policy Researcher at RAN, and she works in the Santa Monica office. So we can't thank you enough for taking the time to join us today. We are so thrilled to share the IDEAS project with you. So on today's call, we're going to talk to you about the project, what is involved, and why you may want to enroll and how to do so. Next slide. So while the IDEAS project is open to all hospitals and clinics, this introductory webinar is designed for clinicians and staff who work in the rural health space, rural health clinics, and rural hospitals. We wanted to make sure that we talked about the IDEAS project in the context of your workflow, your operations, and your staff. So this is that kind of safe place to talk through all of that. However, I know that very specific questions are going to come up for you. And so please know at the end of the webinar, we're going to share our contact information with you. So you can reach out to us and have that call one-on-one to talk through how we can make the IDEAS project work for you and bring these resources to your clinicians and staff.
Let's go to the next slide. All right. Well, hello, everyone. I'm thrilled to see so many familiar names and faces here today joining us. I know that this is a group of rural hospitals and rural healthcare professionals who are really, really committed to patient safety. So thank you for joining us here. Just briefly, I think as many of you know, diagnostic safety is really a critically important aspect of patient safety. We know that diagnostic safety events contribute to preventable harm in many, many visits, up to 1 in 20 outpatient visits and up to 250,000 inpatient stays each year. And in fact, they're actually the most common root cause for medical liability claims. And for all these reasons, and then of course more to prevent harm, healthcare organizations and clinicians really need actionable and practical, easy to use, flexible resources to support their efforts to improve diagnostic safety. So you may have seen the recent issue brief, from AHRQ called Diagnostic Excellence in U.S. Rural Healthcare, a call to action. There's a link in the chat for you to review that. But among the many insights that were contained in that brief, there's one that stood out to me in particular, and that's this notion that we only get one chance with patients in rural settings, meaning that once they're referred out of the community to larger or academic healthcare institutions, the chance of them returning for care in our community or in the communities that they came from decreases significantly. And by ensuring that all of our rural clinicians have the resources they need for diagnostic excellence, we can combat that by providing the excellent care that obviously I know all of you strive to provide for every patient. The IDEAS project and the AHRQ diagnostic excellence tools are a really important component of the rural healthcare portfolio of patient safety resources. So with that, I would like to turn it over then to, on the next slide, to Dr. Alawalia from RAND to talk for the next few slides here.
Thanks, Kim. So I think Kim laid out really nicely how important diagnostic safety is. I think we all know that, but hearing the facts so explicitly really reinforces that. And in fact, many of you might know that improving diagnostic safety and quality is a priority of the Agency for Healthcare Research and Quality, or AHRQ. To that end, they've developed several resources to promote diagnostic excellence. These include a series of issue briefs on different diagnostic safety topics, as well as the 3 diagnostic safety resources that we will be talking about as part of this implementation project. So 2 of the resources, Measure DX and Calibrate DX, were developed for AHRQ by the Baylor College of Medicine and pilot tested. And the 3rd resource that we'll talk about, the Patient Toolkit, was developed by the MedStar Health Research Institute. AHRQ knows and is really firm about this, that in order to promote resource use in actual practice, we need to work directly with healthcare organizations in urban and rural settings to provide training and implementation support, as well as offer you support to continue to use the resource once the project or the implementation period has ended. So with this in mind, they awarded a contract to RAND with the goal of having each of these 3 resources implemented in at least 50 healthcare organizations across the United States. So this webinar is intended to provide you with some high-level information to decide which one of these resources might be right for your organization, and hopefully to decide to participate in the IDEAS project. Next slide. So our project really aims to support diagnostic safety across different settings and across different kinds of users. So we're trying to be as flexible as possible, keeping in mind sort of the variation in clinical practice and clinical resources. I mentioned the 3 resources that we're supporting as part of this project. I'm going to give you a quick overview, and then we're going to move into diving into each one. So the first, the Toolkit for Patients to Improve Diagnostic Safety. This is intended to be used mainly in office-based settings by clinicians and their patients. And this one really focuses on improving communication during the patient-clinician encounter. The second, Measure DX, can be used really in any healthcare setting where there is a QI or a patient safety team, even a small one that exists, or a QI or patient safety team that could be stood up. And this resource is really intended to help organizations identify and use existing data, so data you might already be collecting, to measure diagnostic performance, and then to identify ways, again, with our support, to try and improve that performance at the organization. And then finally, Calibrate DX also can be used in any healthcare setting in which there are at least 2 individual licensed clinicians whose scope of practice includes diagnosis. We can certainly think about smaller practices where there may only be 1 clinician whose scope of practice includes diagnosis, and work with that organization to figure out how we can best support you to implement this particular tool. And this one really focuses on helping clinicians review their diagnostic performance by looking at actual cases that have happened in the past, and improving what we think of as diagnostic calibration. So what's nice about these 3 resources, you can see, is that they really complement one another. One is focused on clinicians, one is focused on the clinician-patient encounter, and one is really focused almost at a systems level at data and measurement. And so they really complement one another, and they address multiple levels of the diagnostic safety process and enterprise. We really hope, because of this sort of complementarity between the 3 resources, that organizations who want to participate in the study might choose to use 2 resources together, or even all 3. One is certainly fine, but they do really work well together. And again, as you'll hear later in this presentation, there is a lot of support from our team to get these off the ground at your practice. So with that, I will turn it back to Alex.
Thank you. Next slide. So the vast majority of diagnostic errors, almost 80%, are related specifically to the patient-clinician encounter. and over half of these failures happen in the ambulatory care setting. So the toolkit for engaging patients to improve diagnostic safety was developed in collaboration with both patients and clinicians. And it's simply designed to improve communication. And I think we can all agree, relationships are better when we communicate effectively. So the toolkit combines two really to use, easy to launch approaches to do just that. So next slide. So let's talk about that first resource. The first one is called Be the Expert on You, and this is the patient-facing component. And it's simply a worksheet that helps patients to prepare ahead of time for the visit so that they can surface their concerns more easily and be able to communicate that effectively to their clinician. I know a lot of us, all of the ideas and conversations, talking points go out the window when we get into that exam room. And so this is designed to keep the conversation focused. The other component, again, is very simple. It's called 60 Seconds to Improve Diagnostic Safety. And this is a clinician-facing component that helps them to just practice listening, actively listening for the first 60 seconds of that encounter. So again, this is all about enhancing communication. And we've heard that this has been effective in improving patient satisfaction. And clinicians who have tested the tool express to us that it helped them to get back to what brought them into medicine, which is taking care of patients and not EHRs. Next slide. So who can test the toolkit? While AHRQ recommends that at least 2 to 3 clinicians test out this toolkit at any given site, we know that is not always the case within the rural health environment and in rural health clinics. So know that if you have an engaged solo clinician who wants to take this on, we will help support you in any way that we can. And so we hope that you'll reach out to us and we can work together in a way that will make that work for you. And also know that we are looking for both primary care and specialty practices of any type. So we've got a wide range of practices that you can engage with it. So as you're listening to all of the resources that we are talking about today, I want you to keep the toolkit in mind because we think that this is going to be the most fun, the least burdensome for our rural health clinics to take on. Now I'm going to turn it over to Kim.
Thanks, Alex. We can go to the next slide here. So the next resource is called Measure DX, and this is really designed to help quality improvement work or help quality improvement teams actually to identify and use practical measurement strategies to detect and analyze and learn from diagnostic safety events that happen in the organization. And what's nice is that organizations are really encouraged to simply use their own existing data to reduce diagnostic harms at their organizational level. Briefly, Measure DX helps healthcare organizations identify, assess, and learn from those diagnostic safety events, and it's specifically designed to leverage existing data. It supports quality improvement teams in creating a systematic approach to improving diagnostic accuracy. And for rural settings, given the challenges of diagnostic accuracy in rural settings, Measure DX is going to enable rural hospitals and clinics to utilize existing data to pinpoint diagnostic safety issues, which can be crucial given limited resources. So, and also on this, for quality improvement leaders, this tool provides a structured way to track and analyze diagnostic performance, which creates a foundation for measurable improvements in patient safety. If we can go to the next slide, I'll get a little bit more in depth to how Measure DX works. So through a 4-step process, Measure DX enables healthcare providers, particularly in rural settings, to detect and reduce diagnostic errors. And as part of AHRQ's IDEAS project, Measure DX offers rural hospitals and clinics the opportunity to enhance diagnostic excellence. It's bolstered by training, resources, and collaborative support here. There are 4 broad steps to Measure DX. The first is to prepare to measure diagnostic safety and ensure that the effort has full backing across your site. Then to assess organizational readiness through a brief self-assessment to decide on a measurement strategy that ideally leverages existing data, and then use that strategy to review and analyze cases of interest. So you prepare by engaging your organization in readiness activities to create a baseline for this work. You assess by conducting a self-assessment to understand current diagnostic practices and gaps. Then you decide by choosing a measurement strategy that aligns with your organization's diagnostic excellence priorities. And then you analyze. You regularly review diagnostic cases to extract lessons and inform improvement strategies. And in a rural setting, the nice thing about this step-by-step process is that it allows teams to start small, working with data that's already available, making it feasible even in settings with limited infrastructure. If you go to the next slide, then in terms of who can test out Measure DX, really any healthcare setting or site can do this, including those who are brand new to learning about diagnostic safety and really have no infrastructure in place yet. But we also welcome sites that have a little bit more experience and have been doing this for a while and maybe want to learn to enhance and develop new measurement strategies. We do ask that the sites that participate can create a quality improvement team that has access to patient-level data. We will never see that patient-level data, though, I want to assure you of that, but it's for your own use internally within the organization. Sites could be ambulatory clinics, could be a hospital, could be a specific unit within a hospital, like the emergency department, mother, baby, you name it. There's lots of ways to determine a site. So then moving on to the next slide, our final tool that we're going to introduce is Calibrate DX. So Calibrate DX really seeks to improve individual clinicians' diagnostic skills by supporting them in reviewing cases, reflecting on their diagnostic performance with some support and structure, and then debriefing with a trusted colleague. And the nice thing about Calibrate DX is that it really empowers clinicians to learn themselves and be driven to improve their own clinical practice through these structured exercises and tools. A lot of clinicians are already doing this informally and formally through other practices. And we know that clinicians want to go back and see how the patients they treated did. This really offers a framework to sort of maximize learning from that and do it in a more supported way through the project. This tool is particularly beneficial in rural healthcare settings where opportunities for peer feedback might be limited. And it does this by fostering this culture of self-reflection and continuous learning. Next slide. So a little bit about how Calibrate DX works. This one also uses a four-step process. Calibrate DX guides clinicians through a structured four-step process of exercises, which is where they're specifying areas for calibration, evaluating their own personal cases, planning and applying improvement strategies, and then reflecting on outcomes. Through this four-step process, then clinicians can reflect on their diagnostic performance, identify areas for improvement, and implement strategies to enhance diagnostic accuracy. So we first ask participating sites to decide which area of practice they're going to review. It could be high-risk situations, it could be commonly missed or delayed diagnoses. And then we ask that site to pull 3 to 5 of their own cases to review and learn from, again, with with the supportive structure that we have in place based on the findings. And then you plan and apply those improvement strategies and implement those improvement strategies. This again could be at the clinician level, could be at the organizational level, and the benefits of this is that this iterative process promotes this culture of self-reflection and continuous learning, which is essential for maintaining diagnostic excellence. Next slide. So in terms of who can test Calibrate DX, what you will see officially is that it's really any site that has at least 4 to 6 clinicians willing to commit to testing it. However, and this is a big however in rural settings, we will absolutely consider fewer participating clinicians if your site is very small, which we understand is the case in many rural settings. We understand that the unique challenges that a rural setting may have in meeting this requirement, and we are absolutely, and by we, I mean AHRQ, RAND, Convergence, and our partners at IHI too are committed to making participation viable for these settings. So please don't let that be a barrier to entry for you. We'll go to one more slide. This next one, why participate in this project? So, I mean, hopefully we have piqued your interest in the resources themselves, but you might be wondering why you'd want to participate in a project for this. And we know that obviously there's interest in implementing something that is new and innovative for advancing diagnostic safety, the goal of improving outcomes for your own patients and minimizing risk of harm. But there's also some additional benefits that participation will provide. So, you know, the nice thing is you can use these resources, get very tailored support and training as you're implementing them. If you're interested in talking to peer institutions or other places across the country, we offer a learning collaborative that's going to be meeting monthly during the implementation period. So that's an option for those, you know, if you'd like to put your heads together. And I know that, again, recognizing so many familiar names on here, I know this is a group of folks who do incredible work by collaborating with others. And so you'll be able to get information on the impact of the intervention, of the interventions that you're putting in place with aggregate data fed back at the end of the study, where we will be offering free CE credits. And we have been able to receive authorization from ABMS to provide maintenance of certification, or MOC, improvement activity credits for physicians in specialty organizations. And then finally, we offer a modest stipend just as a thank you to sites for participating. Next slide, I'm going to turn it over to Alex to close us out.
Thank you, Kim. So Kim actually covered a lot of the support that we will be providing within the IDEAS project to the participating sites, but I just wanted to add a few more things. Firstly is that we're going to be providing flexible training for all of the sites regarding each of the resources, so that you feel really comfortable on how to utilize the resource and implement the resource. And that training is going to be, again, very flexible and very minimal, and I think it's designed to be 2 or less hours over a course of a couple months. In addition, you are going to receive hands-on assistance, including a dedicated email for questions, office hours, one-on-one support, you name it. We are really here to help you during that training and implementation period. And then lastly, we are going to be feeding back to you the impact of the interventions in the study. So to be able to do that, we're going to be collecting some very minor data points from you in the forms of surveys and other types of questions, just really getting your feedback on the use of the tool, the implementation of the tool, what was the impact from your point of view on patients, clinicians, and what have you. So that will be collected throughout the life of the study and then, of course, shared back to you. Next slide. So now let's talk about what is needed to participate. So firstly, it is going to require a 2-year commitment, but please know that the participation and energy required from you for each of the resources will ebb and flow. And of course, like any project, the most upfront time and energy is going to be during that training and implementation phase. And like any project, we want to make sure that you're able to demonstrate executive support, since this is a 2-year project and you really want to have that momentum and support throughout that 2-year time period. We also encourage our participating sites to identify those site participants early on, because they're going to be asked to engage and, of course, participate in those small data collection activities. And so that's simply the clinician who is going to test out the toolkit, and maybe the members of the quality improvement team who are participating in MeasureDX. To sort of keep the train going and on time, we also encourage all of our sites to identify that site champion, and they're going to be the coordinator who's going to help with the training implementation phase, and of course be our point of contact within the IDEAS project to talk through all of those elements. Next slide. So here is the timeline. And so you'll notice right off the bat that we have a staggered start dates for each of the resources that we've shared today, and that's by design, because we certainly want to allow sites who want to do all three to do all three. But if you like to do one, that is a-okay. So right now we are in the recruitment phase, and this is going to go through September of 2025. So there's plenty of time to think about this, to socialize the resources within your organization, attend another informational webinar, reach out to us if you'd like, but plenty of time to learn more. And then starting in March of 2025, we're going to get going firstly with the toolkit for patient engagement. So that really flexible training period is going to be from 3 months, from March to May of 2025, followed by the implementation phase, which is going to last around 9 to 10 months, and then that 12-month sustainability phase. So you're going to get a lot of hands-on support during that training and implementation, but you're going to feel a step off during that sustainability phase, and that is by design, because we want to see how these resources live out in the wild without those training wheels. So that's going to be the time we'll be checking in with you and seeing how those resources are sustained without continued support. Measure DX is going to be the next resource that's going to be launched, and that's going to be starting to become available in June of 2025. Again, following that very same timeline when it comes to training, implementation, and sustainability. Calibrate DX will launch in August of 2025. We're really excited about these resources, but again, you have plenty of time to think about it, reach out to us, and learn more before you decide to enroll. Next slide. So now we've shared a lot about the resources today, and we want to make sure that you have time for questions. But before we do, there are a lot of resources online to support your continued learning. So to learn more and to access some one-pagers about the individual resources, or to sign up for an upcoming webinar, please visit our website at ahr2.gov/ideasproject. If you want a quick and easy way to get there, you can also utilize that QR code on the screen that you see in front of you. If you feel like, I need to think about this, I need to schedule some time with you one-on-one, you can absolutely do that. Please utilize our ideasproject@rand.org email to do that. So thank you so much for listening, and now it's the time to answer any questions that you might have. So you can ask those questions utilizing the chat box, or feel free to unmute your line and ask those questions out loud. Anyone from my team or the RAND team, anything you'd like to add?
I know sometimes there's a lot of information coming out here too. We will get a recording of the video, the slides, the transcript also. Everything will be going out. We will let you know where that will be posted on the AHRQ Ideas website. And if you would prefer to ask questions, have a not in a large group setting, we truly do want to hear from you. So that ideasproject@rand.org is a great way to get in touch, and we will set up a time immediately with you. All right, folks.
Just wanted to thank everybody for joining today, and just echo what Kim said. If you email ideasproject@rand.org, you will reach either myself or Sangeeta directly, and we'll be happy to really answer any questions, even if you're just in the early stages of thinking about it. And I do see someone asked, will we be able to learn from others' experiences with this? Absolutely, that is our whole goal of doing this. So when the project is finished, we'll be sharing the training materials that were used so that anyone can use them. We'll be refining the resources will be refined if needed. And we hope that those that participate are going to learn a ton from each other. I really believe that you, as sort of the front line of patient safety, are the best teachers of each other. And so we really hope this will be a collaborative experience where we're kind of providing a structure and some guidance and some benefits to participating, but would love you to join. And I see someone else asked, is this focused specifically on rural hospitals and throughout the US? This is a national study, so we're looking for sites throughout the US. We're not specifically focused only on rural hospitals, but it is a priority to ARC to make sure that rural hospitals and rural office-based practices are included in this. So we're being maximally flexible to account for any of that rural context as well. We'd like at least 10% of the sites to be rural, if not more. And we will also connect sites that are rural to each other so that you can discuss any particular barriers as they come up. And Sankita also noted that we're hosting learning collaboratives. So for example, we might have rural specific learning collaborative meetings that Convergence hosts where you'll really get to connect with each other. And again, happy to work with any sites if you don't think you have the numbers or just have any questions about the effort required.
All right. Well, thank you so much, everyone, for joining us. I know that I speak for my team at Convergence. We are really excited for this to get going and for the opportunity to get to collaborate together with anyone who would like to join us for this. This is actually a pretty fun project, I must say. It feels like getting back to the real roots of quality improvement and patient safety and making an actual difference in the world here. So thank you. I know you all do that every single day. And once again,